we got a minute. So I'm going to be on first, then I'll bring you all on so you can breathe for a minute. Exactly.
So when we're not speaking, do we just turn our video on so that it can focus on those who are speaking? Or are they going to see the squares?
Okay, and we're live on Facebook. Hi, I'm Dr. Jill Harkavy Friedman, Vice President of Research at the American Foundation for Suicide Prevention. I want to welcome you all to our town hall and want to take a moment to tell you a little bit about AFSP and then introduce our speakers. So the little about me, I am a suicide researcher and clinician in addition to being Vice President of Research. I've been in the field for 35 years. I kind of like to say when there wasn't a field of research, because nobody would talk about it and there was no money for research funding. But through funding, a lot from American Foundation for Suicide Prevention, we now realize that there's a lot we can do to prevent suicide. So let me tell you about American Foundation for Suicide Prevention. We're a grassroots organization. We have chapters in all 50 states, and our mission is to save lives and bring hope to those affected by suicide. And we do that through research, education, advocacy, and support for people affected by suicide. So if you want to learn more about us, I highly recommend you go to the American Foundation for Suicide Prevention's website at afsp.org. So now I'm going to take the time to introduce our speakers. We're very fortunate to have three excellent speakers with us today. First is Dr. Rita Walker, who's a licensed psychologist and award-winning professor of psychology. She's published more than 60 scientific papers, and they're on psychological risk and resilience in the African-American mental health community. And she's been cited on many popular appearances like the Good Morning America show, the Washington Post, Los Angeles Times, and Houston Chronicle, to mention a few. Her recently released book is The Unapologetic Guide to Black Mental Health. Our second speaker is Dr. Regina Miranda, who is a professor of psychology at Hunter College, where she directs the Laboratory for the Study of Youth Cognition and Suicide. She's a faculty member in the Department of Health Psychology and Clinical Science at the Graduate Center for the City University of New York. Her research focuses on understanding why young people think about and attempt suicide and ways to inform assessment and treatment. And one of her main areas is to understand the interplay between culture and cognition in explaining risk for suicidal ideation and attempts. Dr. Miranda is the daughter of Honduran immigrants and a first-generation student in the United States, and she received her bachelor's in psychology from Yale University and her PhD in clinical psychology from New York University. She is also co-founder of the Youth Suicide Risk Consortium, who had their first conference this year. And last but certainly not least, Dr. Sean Joe is the Benjamin E. Youngdahl Professor of Social Development. He's the founding director of the Racing and Opportunity Lab at the Brown School in Washington University in St. Louis. His specialty is in suicidal behavior in Black Americans, with a particular focus on firearms and their role in suicide prevention. And he works with urban Black youth and young adults to help prevent suicide. So panelists, welcome. I want to start by giving you each a little bit of time to introduce yourselves, but I want everybody to know two things. We don't have enough time. I can say that from the beginning. These are incredible people who have a lot to say. So we'll have way more to say. Second is we're going to try to get to all your questions, but I make no promises. We hope you have a lot of questions and that we can't get to all of them. So first, Dr. Walker.
Well, good afternoon, and thank you so much, Dr. Harkavy Friedman, for your very generous introduction. I am Dr. Rita Walker, and I really stumbled into this research in part because I was primarily interested in, what mental health challenges looked like, especially in the African American community. And fast forward a couple of decades, and what I saw was what seemed to be a crisis in the African American community, or mental health crisis. And I don't think that the community was as aware of what was going on behind the scenes as we needed to be, because we have to be able to prevent challenges and not react to challenges. So I wrote the Unapologetic Guide to Black Mental Health, primarily because of suicide crises, particularly in young children. But my concern was that there was a lot of unaddressed, undiagnosed, untreated challenges among adults. So I'm really glad that AFSP has hosted this conversation, or these series of conversations, so that we can share more about what we know and try to get, more folks on board and get more hands on deck with regard to these important mental health challenges.
Okay, Dr. Miranda?
Thank you for having me, Dr. Harkavy Friedman. So as you mentioned, I'm the daughter of Honduran immigrants and a first-generation college student, and I work at a public university that serves first-generation college students, many of whom are immigrants and students of color. And I'm a youth suicide researcher, and I focused a lot on the types of thinking styles and ways of thinking that lead young people to think about and attempt suicide. And also trying to classify different types of suicidal thoughts in a way that might help clinicians be able to predict whether someone's going to go on and attempt suicide, and also how soon they're going to go on and attempt suicide. And it was really my students that drew my attention to the role of race and culture in suicide risk. Much of suicide research focuses on white populations. Research by Christine Cha and colleagues suggests over 70% of longitudinal studies do. And so given the increasing diversity of the US population, our lab has seen an increasing need to diversify our samples. And also it's been a passion of mine to diversify our profession and to diversify science. And so I've spent over 10 years working with programs to diversify the research pipeline from graduate school to post graduate school. And that's kind of what led me to work with other colleagues to found the Youth Suicide Research Consortium, which seeks to increase diversity in youth suicide research and to allow communities of color to see themselves represented in the researchers that work with them. And so that's one of my passions is studying cognition and youth suicide, and the other passion is diversifying our field.
Great, and Dr. Joe?
Well, thank you, Dr. Harkavy Friedman, for inviting us. My work began in this field about 25 years ago. And it really started because I was really focused on the experiences of Black youth, Black males. And I was curious whether or not, and at that time, there was an idea that homicide was the flip side of suicide. So I said, let me take a look and see what was happening. And there was very little work around at that time in the mid 90s when I began in this field. So that's really what got me engaged in suicide research. So the more that I was focused on interpersonal violence, the more other people asking me, well, tell me more about what's going on with Black youth and suicide. So that's really how I got into it. And then I committed my professional career to advancing that work. And again, also like Dr. Miranda, trying to ensure that we have enough of a diverse scientific workforce to do this type of science. So that's always been a passion. So I have focused primarily on understanding, primarily as a social worker, because that's my background. How does an individual fit within society, and how does that fit? How does that context, that ecological context, changes their risk for suicide or any psychiatric disorder or psychological distress? So a lot of my work focuses on the idea now about how does inequality begins to condition the risk for suicide, and particularly highlighting what's happening with Black males, who I think is among the most vulnerable in American society. So I'm happy to be here, look forward to this conversation, and ready to hopefully engage in a discussion that leads to a little bit more inspirational and idea of hope, but really help us to move towards a more perfect union. And how do we address this issue of how does context create despair, which leads to suicide risk?
Thank you all. I told you they were terrific. So I just want to point, just say on behalf of the American Foundation for Suicide Prevention that as a mental health organization, we are committed to ending racial discrepancies. We realize that change has to happen and that it's going to be a long process. And we hope to be a catalyst in that process. And research is one way that we gain information so that we could expand what we know and what we can do to bring greater equity in at least our area's mental health care. And so, and our research program is also geared towards that as well. So let's start off with, the basic thing that I'm going to ask you about is what do we know, which is important for everyone to hear so that we can take that information and move it forward into our communities, into our clinical work. And then the second part is going to be what do we need to know and how the heck are we going to do that? So that's what we're going to talk about today. So I want to start first with Dr. Walker. You've done a lot of work in the Black community and mental health. What do we know about suicide and suicide prevention in the Black community?
It's interesting because I think that those of us who've been doing this work for a while know that there's not a lot that we know about suicide in general. We know suicide is complicated. We know that, one set of risk factors might lead to suicide death for one person or a suicide attempt, but not for another person. And that's part of the complexity of this work. And I would say that for Black people, people of African descent, we know even less. But what we do know is that the myth that Black people do not die by suicide, and it's a very common myth, especially in the Black community, that myth is not true. And that young people, middle-aged people, seniors, people across the developmental spectrum are at risk for suicide. Some of the risk factors are similar as they are with, the broader population, that are symptoms of depression and symptoms of anxiety, untreated mental health distress. But one of the things that I've observed in my work, and I know that my colleagues have also, is that there are important protective factors that are also in place so that maybe the suicide death rate might not even be as high as it could be when we think about suicidogenic factors, when we think about being socially marginalized and not being integrated in a community, when we think about, like I mentioned already, untreated anxiety and depression, which when we look at statistics, it seems to be comparable in the Black community compared to our mainstream society, but doesn't necessarily translate to the highest level of suicide risk. And so there seems to be a disconnect on some level between there being a lot of suicide risk, but not the level of death that's commensurate with the risk. And so that's one of the questions that I think would be important for us to continue to try to address going forward and understanding more so protective factors, investing more so in understanding what is that safety blanket for Black people in our society who've been struggling for generations. So there are some in our communities who are starting to realize like, oh, racism is bad. Black people have gone through a lot in our society, but Black people have known this for some time now. But somehow there's this sense of, can-do, resilience, community, fight no matter what, that I think translates to some of the resilience with regard to suicide crisis in the community. So I think what we know is that we need to know a lot more. That there are similar risks as there are for, the broader society. Racism does, and this is relatively preliminary research, but racism isn't just another stressor. Racism is something different for marginalized communities that we need to better understand. But as we think about going forward, I think we do need to invest more in understanding the safety net or the resilience or the protective buffers, as they might relate to family, spirituality, a sense of connectedness to one's community. So it's not just me, but I am part of a very resilient community, and that being an important part of someone's cultural identity and finding out more about the mechanism for that and how it works.
So we see that, despite that we have a lot to learn, that we can learn a lot about the positive things that help protect people, especially Black people, from suicide. But we can, just whatever we learn from any group, we want to see how that fits with other groups. So we have a lot to learn from this work in Black mental health. So Dr. Miranda, I want to ask you, what else do we know? What have we learned about diversity and cultural, impact on suicide and suicide prevention?
So first, I think it's important to keep in mind that suicide looks slightly different in communities of color than among white communities. And because the literature has been built on suicide among white communities, where suicides tend to happen when people are older. So in middle age, it used to be that the typical profile of someone who died by suicide was someone older than 65, and now in recent years, it's someone in middle age in their 50s. And so that has been the profile around which suicide theories have been built. But it looks different in communities of color. So we know that generally in the United States, the time of life when people are most likely to think about and attempt suicide is when they're teenagers. But among white communities, when they're most likely to die by suicide is in middle age. However, among communities of color, that's different. And so among Black, Latinx, Asian, Native American communities who die by suicide, the age of onset of ideation attempts is also in adolescence, but age of death by suicide tends to more commonly be when they're younger, in their early to mid 20s. So we need to do more research to understand those differences. First of all, and to build our theories around those differences, and to look at factors that are unique to each of those communities. We also know that suicide rates are highest in the United States among American Indian and Alaska Native communities, and where the suicide death tends to be also highest when people are in their 20s. So it's the attempt and death rates that are highest when people are younger, and where the rate is actually even higher than among white communities. So we need to do more research to understand suicide among Indigenous communities, and echoing what Dr. Walker said, really understanding the role of race, and maybe race as a form of trauma that may impact, or that may lead to those earlier deaths among those who die by suicide, who are people of color. And I agree, and resilience factors, because the attempt to death ratio is higher. So we know that, for example, Black and Latinx teenagers, over the trajectories have been going up for suicide rates across age groups, including youth. But data from the Youth Risk Behavior Survey, so for several years over the past decade, Hispanic adolescents had higher rates, and those rates went down in recent years, although some people think that might be an anomaly. But actually in the last two YRBSs, you see that the trajectory for Black youth has been going up. And that, I think, is accounted for by Black girls. So, so that's important to understand those trajectories and the factors that lead to the change in those trajectories.
Thank you. So we really need to understand this in a deeper way. And I think you're highlighting how we can use some national resources like national surveys and healthcare interventions to learn more and then help communities to prevent suicide. So Dr. Joe, what do we know about the impact of systemic factors on suicide?
Well, as my colleagues have pointed out, so for Blacks, suicide, you're talking about those under 35 with highest risk. We see more recently with the data that tells us now that each succeeding generation, the risk gets higher. So now we find that Black children, and that's related to our Ring the Alarm report, that Black children under 12 now have higher rates of suicide than white children under 12. So these sort of things tells us as the developmental context for Black children are changing, it's elevating their level of risk for suicide. So we have to pay attention to that. As Dr. Walker mentioned, the research is now beginning to look at the ecological factors. So this issue of stress, and particularly racism, how it plays out in the lives, we're now looking at that in addition to looking at access to mental health services within the region and whether or not that elevates risk. But all of this is preliminary. I've been involved with this since 1994 when I did my first study. And we find that the commitment to advancing science in this area is not on par with the rhetoric that's out there. So I just want to be very clear about that. So we need to do no more. We know that in terms of actual interventions and treatments that work, we have less than 3 that's been associated with any reduction in suicide risk. And that's really whether reduction in ideation or a reduction in some level of attempts, but even the attempt studies are very few. So for a lot of ethnic minority groups, we don't have the science to tell us what works, but we've been increasing our understanding that this impacts those populations, whether it's communities, any communities of color, whether it's the young who tends to overwhelmingly suffer the burden of this, but in particularly for my work, it's the males. So if you look at Blacks, pick an age group. Black males are going to account for 60, 80, 85, close to 90% of those suicides. And if you look at non-fatal suicidal behavior, it's clear. Black males have always reported more attempts on one of the national surveys, which is the Youth Risk Behavioral Surveillance, more attempts than white males. And more important, when they do attempt, it requires more medical attention. So all of this has been going on. But this is not just about the ethnic minority groups. Our commitment to really advancing strategies to better understand how to reduce people's risk to environmental stressors. This is the first time, for example, in American society that we've asked whites for years. This is the first time they believe that the next generation will not be better off than the current generation. Now, for ethnic minority populations, that's not a new phenomenon. The idea that our opportunities are not limited by our individual capacity, but our opportunities are limited by context. So economists have really, from Princeton, really kind of speaks to this, and they call these the deaths of despair. The idea that context matters. So one of the things we're all paying attention to right now is that with the pandemic and with the different ways it's impacting families and the grief or the economic stress of this recession, what's going to happen? And many of us know and think that it's not now, but in the months ahead, the 18, the 12, the 22 months ahead, you can see those things start to show up in not only in our emergency rooms for suicide attempts, but in our children, given again the way they're experiencing schools. So those are critically important. So I think there's needs for equity in priorities related to suicide research that will help us better understand what to do. But I also think there needs to be equity in priorities where states have the ability to, at least right now, try to know what's happening with their population and prepare the behavioral health care system for what is coming. And that's going to be a bigger wave of grief, and it's going to impact not just Black and Brown, as it's impacting rural communities, and as Dr. Miranda pointed out, it's impacting those middle age, and it's particularly an increase that we've seen in the last 20 years in white female suicides and white male suicides, particularly those in the middle ages. So equity is a critically important factor.
And I think that COVID has done a couple of things related to that. One is it's the first national event where the first thing that people started talking about was mental health. And so we've already started a new era in mental health care, with each of us thinking about our mental health and attending to it. I'm hoping that will make a difference as to what happens down the line. But it's also highlighted the lack of resources that have been directed to both mental health care and mental health research. But the other thing it's really highlighted is the inequity in our system. And that inequity is also being shown in the fact that we don't know that much because we don't have the research. So now I want to turn to the next question, which relates more to what do we need to do? And I know you've spoken a little bit to that, but if you maybe think about what you in particular might want to do to enhance what we know about ethnic underrepresented samples, and what are we going to do with that information? So I want to start with you, Dr. Miranda, and I want to ask you, because we had a chat about this, how does the inequity in the health system affect what we learn from research?
Well, we know that lower income communities and communities of color have less access to healthcare in general, including mental health and access to treatment for suicide risk. I do research in New York City and New York City public hospitals. And what I've noted is that some of those hospitals are affiliated with medical centers, some of them are not. When a hospital is directly affiliated with a medical center, there tend to be more resources allocated to research. The medical center is more of an academic environment where you have a lot of researchers applying for federal grants or private grants. And so there's more funding flowing in to study particular populations. But a lot of the hospitals, public hospitals that I work with, my lab works with, that work with primarily racial and ethnic minority communities, don't necessarily have those direct affiliations. There may be indirect, or often researchers associated with the more well-funded medical centers are less willing to travel to do research in those settings. And it's been surprising because many of the clinicians who work in those settings are thirsty for the research knowledge and want to have research done, and are very curious and want to have researchers come in and do the work. But there are often lack of resources to make that happen, particularly if you're not affiliated with an institution that's very research intensive, it's already bringing people in to do research. There is also often a certain amount of bureaucracy involved in getting into those institutions to do research. So I think that people who are used to the easier infrastructure are less likely to want to go in to those settings, because you kind of have to be a little bit scrappier to do the research, and it's very labor intensive as an investigator. You spend a lot of time corresponding back and forth and figuring out, things get lost and then found again, and you kind of do the same things over and over and over again. And so what in a more well-funded institution might not take as long, in a less well-funded institution takes a lot longer. And so I think that sometimes people give up on going into those medical hospitals that serve those communities for that reason, or maybe there's not as much training available for the staff and clinicians, or the environment is not necessarily acculturated to doing research. And so my observation has been that the places we've gone to want to do research, but there are often barriers, systemic barriers to letting researchers go in, or even a lack of willingness sometimes on the part of researchers to go in. And so those communities don't get served as much. And then there might be also fewer systems in place for follow-up. So there tend to be long wait times for suicidal teens. Some hospitals may not have a comprehensive psychiatric emergency program, or may not have an inpatient unit we work with adolescents, an adolescent inpatient unit. So there's a different level of risk involved if you have someone who's being seen in a busy ED that's under-resourced, with hardworking staff, but under-resourced. And then you have very long wait times to get an appointment for follow-up, because there's such a high demand, but at a certain point, fewer places where you can get a quick referral. And I think with COVID and the need for social distancing, that is also more of a problem, because you can't necessarily serve as many people in, say, a day treatment program or an inpatient setting.
So what you're really raising is that the inequity not only affects the access to care, but it affects the research that teaches us some of the, what do we need to do and who do we need to do it for, so that we don't even develop the care to provide to people in all different kinds of cultural communities. So Dr. Joe, how do we change that? How do we change the lens to allow for equity in both clinical care and research? I'm not asking you for a solution. That's a long question, But let's focus on research. What can we do to get that work moving forward?
Well, I think it's for the bodies that fund the research, like again, AFSP, the National Institutes of Health, the National Institutes of Mental Health, SAMHSA. These groups have to realize this is an important thing to prioritize. They have to prioritize. One of the recent analysis of NIH funding really shows that the reason ethnic minorities, particularly Black Americans, are less likely to be funded is because of the topics they choose. That means they're picking topics that impact their populations. They're picking topics that says that you have to look at the social determinants of health. You have to look at subgroup analysis among Blacks, for example, and not think that all Blacks are monolithic. You have to get deeper so we can begin to have the information that allow us to, one, encourage them to receive services. Two, if they're going to services, make sure those services work. Make sure they do something to help people, you know? And then support their treatment if we can, if they cannot afford it. So it's really up to these agencies to recognize how important that is, that now we're in a context where suicide used to number about 30,000. We're a country now, suicide is numbering over 50,000 people annually. So something is going on in our country and is now impacting all aspects, all corners of our country and all citizens. So it's important, not just for those ethnic minority groups, but if we learn something about how the context and the experiences impact their risk, you're learning something that can inform the suicide prevention for everyone, particularly those who are more marginalized, more oppressed, who have more reasons to consider these sort of approaches for dealing with life, but they didn't do it generations ago. So how do we change it? You got to change the priorities of these agencies to make sure that they recognize these are important topics and make sure that the systems of review does not eliminate the scholarship from being funded. So that's some of the things that you can do in terms of advancing the science in this area.
Yeah, so I just want to mention that at AFSP, every couple of years, we set new priorities. And it's not that they weren't priorities before, it's just that we've learned that when we set a priority for research, it's kind of like if you build it, they will come. So if we set a priority for research, then researchers will study that. And then when 70% of our researchers go on to get federal funds in larger studies and develop careers. So we have set our priorities for the next 2 years to be research in underrepresented ethnic and racial communities in relation to suicide prevention and to support researchers of those groups. And our hope is, I mean, it's always important to study it, but we really want to build the impetus in the community to do that. And by calling it out, we're hoping that that will increase the availability of researchers to study these issues. And so
let me just acknowledge that, because I do, because one, I'm working with one of your fellows now, and I see that's happening, who's picking up some work around Black males, which is sorely needed. But we used to have greater infrastructure for these sort of pipeline strategies, because even if you put the topics out there, you would have to have the workforce to do it.
That's right.
And if they don't really, if these institution, NIH, for example, doesn't make an investment in these minority fellowship programs, these programs which are pipeline for supporting the career development of ethnic minority scientists who are more likely to pick topics relative to their population, like suicide, then again, if we don't fix it at both ends, we won't be able to make the progress that we're trying to see.
That's right. That's right. And so, Dr. Walker, what do you think about research in understanding mental health and suicide prevention in the Black community in particular? Oh, you're on mute.
Yes. Okay. One of the things that I have decided before I run out of my scrappiness, because it absolutely takes another level of scrappiness to do this work and in marginalized communities, that I've invested more in taking the message to the people and trying to get more knowledge and awareness that one, suicide can happen, and that two, the reason that I'm doing this work is because I know it can be prevented. And that prevention, ideally, yes, funding agencies would realize the importance of this work, but until that happens, and I've been waiting myself for a couple of decades, Until that happens, we have to empower the community. And so helping people, it's a public health challenge. Understand, what are the risk factors that are associated with suicide? We have to, be prepared before someone is in crisis. What does that look like? What do you say to someone that you think could be in a crisis and thinking about taking their own life? We have to get individuals better informed. And that's, again, not even just for marginalized communities, but as a broader society. It's just that we have a greater challenge to overcome in those communities that are understandably mistrustful of data, understandably not trusting of those of us, and including us people of color in the ivory tower. Like what are our relationships with those individuals that we can kind of do better to bridge those gaps? And so, before I run out of steam, that's where I've decided to shift my energy to helping the people who are also intervening with their close friends and family members who we don't want to have to go to the emergency department to get mental health care, because that's not where it is. But we know that oftentimes that ends up being the default because there's not enough providers in the community. So again, we have to empower our communities. And one thing I will say, because I won't be able to rest this evening if I don't, is that if we do invest understandably, or exclusively in men and boys, my concern has always been that it begins to parallel what happened in the 80s when there was investment with the AIDS and HIV crisis, and there was investment for men in same-sex relationships who are primarily white. And now who has the highest AIDS HIV infection rate? It's Black women. And so I'm always hopeful that we can make sure that we're, equally investing if we can, in all of our sub communities or subgroups, so that we don't end up leaving groups behind.
Yeah, and that depends on all of us researchers. And it also depends, one of the things I love about AFSP. So I have to confess that I got my first grant from AFSP in 1992. And that I was immediately connected with them because of the mission. And some of the things that we do, like having walks, although now we can't walk together necessarily, but we find ways to have experiences together to build that community will. And that community will then also pushes the research. And it also, with our advocacy department, we literally, we find it, we give everybody a tool to directly connect with their legislators so that they can make a difference. And that takes all of us. And so those are opportunities that people from every community can take up. And we are seeing the difference. And we're committed to engaging all communities in suicide prevention and in those activities. So, we know we have a long way to go. We have a lot to learn. Just because you say do this doesn't mean that people feel welcome or they have the tools or the backing to do that. So we realize that we have a lot of work to do in our community and in the larger community. So really appreciate that. Now I'm wondering if, I think we're ready for some questions. So you guys ready to answer some questions? So please bring those questions in. I've got my little thing here that I'm looking. While we're waiting for some questions, I guess I want to ask, you mentioned about how difficult it is and you have to be scrappy to stay in this field. And I certainly know that, because when I got in the field, nobody would talk about it except in the ladies' room. And then it made its way to the dinner table. And oh, good, we have a bunch of questions. So I'm going to go right to the questions. So one of the questions that we got was, what are specific interventions that can help safeguard our mental health so that we don't get to the point of being in a crisis and having to start at that point? And so, Dr. Walker, I'm going to ask you, because you talked about the use of the emergency department. And if anybody else wants to pipe in, please feel free.
One of the things that I don't think we do a good job of in our society is our own self-assessments of where we are. So as an example, I might ask someone, how are you doing? And they say, oh, I'm fine. Some folks in the Black community might say, I'm blessed and highly favored. But what does that even mean? I don't think that we do a good job of just honestly taking stock of, on a 0 to 10, and I talk about this in the book, like on a 0 to 10, 0 being, the worst we could possibly imagine feeling, and 10 being the absolute best. How am I honestly feeling today? And if someone is, consistently falling below a 6, like consistently, then it may be time to do something different. Now, the something different, varies by person. Some people may need to see a mental health professional. So at the point where, as an example, they're not able to, do their work, take care of family, and I know all of this is hard in the middle of a pandemic. My coworker is here now under the age of 10. All of this is hard work. But if we're just not able to do it, sometimes not feeling like getting out of bed or not able to eat, it's worth maybe considering seeing a professional. And we don't have to decide if we need to see the professional. We can call and let them know what's going on so that they can assess. I think a lot of people want to be mental health professionals themselves and kind of self-diagnose, but we're actually trained in that. And so it can help to see someone, but if maybe they're not quite there, smaller things do help, listening to music, listening to maybe inspirational music, calling a friend. Don't wait to schedule the happy hour, just send them the Zoom and say hello, connecting with people with whom we draw positive energy, who can also maybe to help process some of the difficulty of what's going on in our society, so like-minded people. But even as I say that, turning off some of the social media, because the research is consistent around that. It can bring our energy down. So those are just a few things. I'm sure, my colleagues can happily jump in, but those are some thoughts that come to mind for me.
Well, it's interesting because I think what you're saying is know what you can control, know what makes you feel better, and avoid the things that make you feel worse. And we have also, if you're looking for it, we have resources, both broad sources and various sets of resources to share for different ethnic groups on our website. So please, go to afsp.org. One of the things that's hard is when you're feeling crummy is to reach out. But honestly, like any other health condition, if you don't reach out, you may not get that help. And I think I could go on about that, but we have more questions. So what kind of strategies can we develop to handle the economic and access shortfalls in mental health resources for minority communities that would be associated with increased healthcare costs, especially in light of COVID? Okay, so how can we make our resources better? How can we make our access to care better? I think that's the question. So Dr. Joe, we're going to ask you that.
Yeah, so I think, and I wrote a piece about it for this online social work today, that we need a similar kind of CARES Act, but a Behavioral Health CARES Act right now. Mm-hmm. This will be great timing for it, meaning we know that in most areas, it's hard to find a psychiatrist in most areas, and particularly in rural areas, but also in urban areas, that they're struggling to find that. And the psychiatrist is particularly important because they write the medication. Some people are going to need medication, so they're going to need that. So CARES Act, they're really focused right now on increasing the largest component of the mental health workforce, and for me, that's social workers, getting more of them out there, getting more of them trained, getting more counselors trained, increasing the number of psychologists. Psychiatrists will take a little longer, but there are other people who can really help lay support in terms of being a connector for many people. Some people just need a connection that might matter. I focus on work around males, and I pay particularly attention to the role of work. Work is a fascinating thing, in terms of giving people a sense of purpose, giving people a sense that they can move their dreams ahead. And particularly those who are constantly not just having their dreams deferred, but their dreams killed, there's a lot we can do to focus on helping young people or helping individuals cope through and help them to connect to another opportunity to do something meaningful with their life and to be connected to individuals. So right now, federal level, definitely passed the CARES Act around behavioral health care. and strengthen that right now because it's insufficient right now. And then two, you're gonna have to strengthen those social determinants of health and really make sure that jobs and housing, other things that make people even feel worse, even if they're having a psychiatric or psychological distress, and then you lose your housing and your lights get turned off and you have no water. I mean, all these things. So people need help and support through those experiences right now. So as much of the dialogue will say, well, that's too frivolous. I mean, this is people's lives. There's nothing frivolous about it. To make sure that they can eat, to make sure that they can live in a warm place, and then they have lights and electricity, and then hopefully a job or something that says life can be better in the future, and give them some sense of hope. So those are some things I would throw out there.
Yeah, that's really helpful. I think what I think you're saying is we have to teach everybody to be scrappy about their mental health. But the other part of what you're saying, and I want to add to that, is when you're not feeling well mentally, a lot of times you lose your lights, you lose your housing, you lose those things. So that's a time when you need the support for basic health, basic living, basic nourishment, you know. So it goes both ways. If you don't have that, that's bad for your mental health. And if you're not feeling mentally well, you might lose those things and need help with that. So those basic necessities are really important. So Dr. Miranda, we were asked if anybody's conducting research on suicidal ideation or behavior using digital platforms in mental health interventions.
Yes, so that is actually a very hot area in suicide research in general. So there are people who are, our traditions have been to assess suicidal ideation and attempts at one time point, and then follow people up over time, maybe in a few weeks, a few months, a year, and then assess them again. And then we miss those daily fluctuations in suicidal thoughts. And so there are a number of labs around the country who are using what's called intensive longitudinal monitoring, where basically they ask people every day to report on their suicidal thoughts and other things that they're experiencing. And so some preliminary research from those labs suggests that there are different, there are some people who think about suicide and have high levels consistently. Some people have lower kind of subclinical levels, and some people, it goes up and down. And so we don't yet know which of those types of suicidal ideation are associated with greater risk for making an attempt. But by monitoring that risk more intensively, the hope is that not only can we better understand what that looks like, but also we might be able to intervene earlier to do risk assessments, because we know that one of the highest risk periods for suicide is once somebody is discharged from inpatient or from clinical care. And so we want to be able to more intensively follow people up. Now, the problem is that that assumes that everyone has equal access to digital technology. And we know, there's a study by Cassie Glenn and colleagues that came out recently that did intensive longitudinal monitoring with teenagers, and there were disparities in compliance with the technology, where racial and ethnic minority clients, I think there was about a third compliance among racial and ethnic minorities versus about 2/3 compliance with about 2/3 of the assessments with white teenagers. And so we have to be mindful and be flexible in considering that not everyone has the same access to technology. And if we're only enrolling people who have that access, then we're going to have a large subgroup of people who won't get represented in the studies.
Yeah, so, and by the way, I believe AFSP funded that study by Dr. Cassie Glenn so that we could learn, do these tools work? And, we can't just make the assumption that if we use technology, it's gonna work. We have to actually test it. And some of the findings suggest it may work differently for different people because of things like access. And access isn't just like, do you have a phone? It's also, do you have a private place? Do you have the time? Do you have the support? so when we talk about access, it's not just whether or not you have a phone. So here's another question, which I think is something you guys can help with. Is there any research that begins to identify groups within the Black diaspora that are at higher risk for suicidal ideation? Who wants to take that question? I can assign it. Okay.
I'll let Dr. Walker go.
Well, actually, Dr. Walker, I think this is in your area. Basically, what they're saying, like, which is true, I think, for every ethnic group. Like, when I check that box of white Caucasian every time, I'm like, no, I'm Semitic. I'm not white Caucasian. So that happens across. Just same thing with Latinx. With we're all not all the same just because of our skin color. So, are we learning some things about different groups within the Black community? Of what the needs are and what contributes to suicidal ideation or prevention and protective factors.
Okay, I appreciate you adding that, because there were a couple of different things that came to my mind. And what I will highlight is something that we've mentioned already with regard to, suicide deaths increasing for children, so 5 to 11-year-old children. And what does that mean for Black people? At the same time, the highest rate of death is for younger adults. And that was mentioned also already. So those aged 25 to 44. And what does that mean for that group with regard to what the risk factors are? So those are some of the things that we know. There has been some research that shows, interestingly, that persons who are from maybe African Caribbean, that their risk has also been increasing. So being, not just someone who is Black, but who also within that community identifies not just as African American, because there is a lot of diversity within the Black community. Those things come to mind right now. And even though Dr. Joe tried to punt that to me, I know that he wants to add to that question.
I'm just a fan, Dr. Walker. I'm just a fan. No, she's right. So in one of the studies that we've done that's nationally represented, that shows that Caribbean Black males attempt more suicide than African American Black males. We find that Caribbean Black adolescents, females, and African American adolescent females report more suicide attempts than Caribbean Black adolescent males and African American adolescent males. So the idea is that there are two large ethnic groups of Blacks in the United States: Caribbean Blacks and African American. And then you have African immigrants, which is a smaller subgroup. So the idea that you have variations among ethnic cultural subgroups is critically important, and we have to pay attention to that. So in our strategies, in understanding who's most at risk. But overall, the main thing to understand is that a person who might be at risk for suicide, particularly in the Black community, might not actually have a diagnosis. They might not be exhibiting depression. They might have exhibiting some level of indicators of anxiety, or irritability. So you can't just look for suicide risk just in the clinic. You have to think that we had 45% of one sample that showed that those young people had no diagnosis, no engagement in behavioral health systems, but they also had attempted suicide.
Mm-hmm.
So we're going to have to look broadly when we think about who's at risk, and again, stay on top of the evidence that guides our understanding of who's at risk.
Yeah, and the issue of mental health is an important one because, well, first of all, we all have mental health, right? So we got to take care of that. I think that was the question before about how do we take care of our mental health so we don't end up feeling suicidal. And if you have a mental health condition, all the more important that you take care of that condition, just like any other health condition. But also, a lot of people don't know they have a mental health condition. So that kind of leads me, it's a little diversion, but to a question that I want us all to discuss, not me, you guys, which is how do we make inroads in communities to break down the stereotypes around suicide? Who wants to go first? That's a big one. Like, let's face it, different communities feel differently about suicide and may or may not talk about it, may or may not address it. So Sean,
this is a complex issue. And so we have how do you do this? This has always been troubling, particularly when you think about universal strategies. So for some, there is some evidence, though small, that stigma protects some from risk for suicide, right? The sense of the stigma of suicidal behavior. Our community doesn't do that. You know, the idea that women live for their children, you know, all these things that says a combination of a variety of factors that suggest that I have to survive this. Whatever it is, I have to survive this. But then the challenge is if you make it normalized, it increases others' access to care. That means they feel comfortable in reaching out. They don't push away their social networks. So it's a complex thing for us to figure out. This is why person-centered, personalized strategies is eventually where we're going to have to go. And we have to be very careful than doing just universal strategies in terms of suicide prevention and in terms of just education and awareness. So it's not a clean answer, but I'm always cautious because we lack so much information. But I know for some, stigma is protective, and for others, it's a risk factor. But nothing is worse than having poor quality behavioral health care.
Right.
Because that norm gets passed on between families, that the treatment wasn't good, the treatment wasn't effective, the talk therapy wasn't effective, the clinician wasn't sensitive, the clinician had no sense of a background and understand the cultural nuances. So I'm more worried about that stigma than the stigma around suicide.
So the stigma of healthcare. So
Of
it's
quality care, right?
of quality care. It's interesting what you say about the value of stigma, because if a person is suicidal, often that just disconnects them from their community because they feel there's no opportunity for discussion. So, you know, the taboo in many of these communities is not really about talking about it and getting help. It's about not doing it because you die at the end. And we're supposed to take care of ourselves and our body and the lives we're given. So other thoughts about how we get rid of these stereotypes? We have 5 minutes left, so we can chat about this. We do have a few more questions as well, but I think this is really important. Like, how do we talk about suicide so that we make a difference?
And one thought I have from the research end is, again, having communities seeing themselves represented in the people who are not only treating them, but doing research. And perhaps increased funding for, and this is an area that, this is not the type of research that I do, but community-based participatory research. One example of that is research by Dr. Alfie Breland-Noble with the ACOMA project with Black youth and depression and suicide risk. But really involving communities, not just kind of sitting in our ivory towers and developing treatments with selected samples, but to really allow for variability in who we see in our studies, and dealing with things not, dealing with the messiness of the data that we get, and then maybe bringing it back to the communities and having them be involved and help us make sense of the outcomes or the findings, and having communities be invested in the work that we're doing, so that there's decreased stigma around not just talking about suicide, but around doing research, and participating in research.
Dr. Walker, did you want to add, or?
Well, I know our time is running out, and I just want to share, maybe there's someone who's listening who is part of the African-American community, and they know someone who has type 2 diabetes. And most people in the African-American community know someone not only who has it, but who isn't managing it well. And one of the things that we also know is that, diabetes being a chronic illness, there's a lot of depression that coexists with having to remember to take medication, having the energy to exercise, take care of one's diet and eat right. And it is a lot. And one of the things that I found in, one of my studies, and I was almost funded by NIH to pursue a larger project related to those persons having fewer reasons to live. So being diagnosed with type 2 diabetes and having relatively elevated depression and having fewer reasons to live, in that when we mix together those factors, those individuals were also less likely to manage their diabetes. And so what I'm saying is that maybe, just maybe, we need to take a really big step back and think about, again, what are the things that are in people's control? You know, meeting folks where they are. People will say like, oh yeah, I know somebody with depression. Like, oh, I have depression. Like, this is something that is very accessible in the community, but maybe treating depression among those individuals and make sure that they're managing their diabetes so that they're able to prolong their lives. So again, going to the community, figuring out what are all the things that we can do systemically in order to prolong life.
So you're also talking about a whole person and a whole community approach, that we don't just separate mental health from the rest of health and act like it's completely distinct, because, you know, that mind body, you know, which is a dualism, that is gone. You know, we know that it's one system of the person. If you're not physically well, you're probably not feeling great mentally. I like to use the example of like, who feels that they can make a good decision when they have a cold, right? So to me, that's like the primary example of how your brain doesn't function that well when you're not feeling well physically. So we're all one, and I think that's part of it. But then that brings us to another question, which was whether or not it's possible, and this is going to be our last question because we're going to almost out of time, to do more screening and risk assessments for depression and suicide in places like family care and other visits, hospitals, schools, bringing mental health screening to the community, and whether or not that might bring us towards more better mental health and suicide prevention. And Dr. Miranda, you're nodding, so you go.
Yeah, I mean, definitely. I think you know, one of the limitations of our research is that we tend to focus on places where people go to seek, you know, emergency departments, people who are already motivated to seek clinical care, but not in places where we know that the majority of for example, adolescent suicide attempters don't seek care, and so we need to go out to the places where we'll find people who are at risk. At the same time, we need to make sure that our screenings are asking the right types of questions, because not everybody is going to interpret the questions in the same way and respond in the same way. So I think we also need to make sure that our screenings are culturally competent.
Yeah, that's great. And in fact, if anybody knows about American Foundation for Suicide Prevention Project 2025, one of the areas that we're working in is large healthcare systems, particularly primary care and behavioral health care and emergency departments, because 83% of people go to their primary care doctor. That's an opportunity to check in and do a mental health check. So I think that it's just at 5 o'clock, and I think we're going to have to wrap it up. But I want to thank everybody. Thank you guys for sharing your knowledge and expertise, and starting on this journey. I'm very hopeful that we're going to stay on this path to make a difference and to improve mental health across the board and address the disparities and inequities. It takes time, it takes scrappiness, but I think we can do it. And I want to thank you all for being here, and have a good afternoon.
You too. Take care.
Thank you.
Thank you.
Bye-bye.
Bye-bye.